Good evening, everyone. I'm Dr. Sanjay Wazir. I'm a consultant neonatologist at Cloud9 Hospital, Gurgaon. Today, we're going to talk about high-frequency ventilation in newborns. I'm sure many conferences you would have attended and many seminars you would have done already. But we thought probably this is something at the COVID time. It's a good thing to revise some of the things which are old, of course, and something which is new happened in the high frequency that we must know as of now. I'm sure during the presentation and after you will probably have many questions. So there is a chat box which is available or beneath the link, and you can just put your questions there and we'll try to answer them, most of them after the presentation is over. So to begin, like high frequency ventilation in newborns has been there for the last 30 to 40 years, largely because although conventional ventilation has decreased the neonatal mortality, but we know 20 to 40% of ventilated very preterm infants do tend to develop a bronchopulmonary dysplasia or other ventilator-induced lung injury. And it's our endeavor to look as we develop with even smaller babies, 500, 600 grams, 23, 24, 25 weeks. There, the risk of bronchopulmonary dysplasia is around 50 to 60% at say 23, 24 weeks. At that time, you would be interested in finding about are there any alternative ways where we can reduce this ventilator-induced lung injury. So the seminar we're going to cover. The objectives today will be to cover one, basic principles of high-frequency ventilation, and then we are going to talk about how we're going to manipulate the machine with different knobs which are available and its use, their knobs used in different clinical situations. This much I'm sure you would have learned earlier in the course of various seminars or even various talks. But what we're going to talk in addition about two important strategies, which at least I have learned in the last couple of years only. One is an open lung ventilation, where we're trying to expand the lung and keep it open, as the name suggests, and a volume guarantee. Volume guarantee is the concept which has been borrowed from conventional ventilation nowadays. Most people would use pressure support and volume guarantee in most of the conventional ventilators. And the same concept to control the amount of volume being delivered to the child during the high frequency is something that we're going to cover additionally as part of this seminar. So basic design of a high frequency ventilator is simple. I mean, it's one of the simplest things that you could possibly think of. There is an inlet. If I can put my pointer here, yes. There's an inlet of gas, and the flow of gas goes from here and through the expiratory valve. So based on either the flow of the gas or the obstruction here, you generate a mean airway pressure, which gets transferred to the patient. And the other part of the important part of the design is an oscillator or a membrane in different ventilators. And in fact, some of the ventilators like Traeger VN500, they have a Venturi effect. So different ventilators would have different mechanisms to oscillate, and the oscillation helps in pushing the gas forward. And when the oscillation goes into a negative mode, it pulls the air back. So that is why we say in a high frequency ventilation, the inspiration is also active and the expiration is also active, except in case of a jet ventilator, which we anyway do not have in India. So we're not going to talk about a jet ventilation. In contrast, when you talk in terms of how this high frequency ventilator differs from a conventional ventilator, the conventional ventilator works on rates we normally talk in terms of 45, 40 to 60, whereas a high frequency, the range was in 5 to 15, 300 to 900 breaths per minute. That's a huge, considering that we're talking about 40 breaths on a conventional ventilator. As I just explained, the expiration is active and the inspiration is also active. And what is more interesting is that we normally talk about a tidal volume of around 5 to 8 ml per kg in the conventional ventilator. But in high frequency ventilator, we're talking about a very small tidal volume, around 2 ml per kg, which is even less than the anatomical dead space for most babies. And not only that, we also talk about a small oscillation. So it could be like, a delta P, which is very small. So you have a mean airway pressure, and on top of it, you have an oscillation which is going slightly up and down. But the delta P compared to a delta P in a conventional ventilation, suppose you set a pressures of 20 by 7, for example, you have a delta P of 13. So that is much lesser, and we'll learn over a period of time that this is what results in a lesser, ventilator-induced lung injury. So in conclusion, high frequency is a distending pressure and followed by oscillations on top of that distending pressure, which is required to generate the tidal volume. The mean airway pressure, if you see in the one which has been painted in yellow on your screen, the conventional ventilation, there is like a map which is based on a PIP and a PEEP and the TI and the rate. So rate is not such a big factor, but like PIP, PEEP and TI and of course the flow. So everything contributes a little bit, but these are the major factors where you would probably talk in terms of a conventional ventilation. Whereas in terms of a high frequency ventilation, when you look at, you have an active expiration and inspiration and active aspiration, and resulting in a mean airway pressure here, and we'll come to how it affects the oxygenation in some way. So when we talk about the mechanisms of high frequency ventilation, so if you see this video, so you see, so it's unlike a conventional ventilation where the breath is going all at one time and then coming. There is a lot of turbulence of air, and there is a gradual dissipation of air from the main airway into the peripheral part of the lungs. The mechanisms of high frequency ventilation, it's good for those who are attempting to appear in the exam or for those who are purists, but honestly, this is something which is beyond a clinical application, so I have not applied too much of a mind remembering that. But for those who are interested, there are articles on the net which will give you a good idea about the different mechanisms. But what is important for us to understand when it comes to mechanism is that there is an airway pressure and this is an important concept which is of a clinical relevance to understand the mechanism. There's an airway pressure here, which is like X, and as it flows down into the airways, there is a dissipation of pressure transmission. So that the pressure transmission, what is happening here, and the oscillations you see here, are much dampened in the area here. And this has a clinic in the area here, which you see, there are two alveoli. One is the alveoli which has a normal compliance, and one is an alveoli which has a lower compliance because of atelectasis or any other issue. So the airways or alveoli which are closer to the airway, they tend to get a higher transmission of pressure, but which are farther away, like if the lung is already compliant in one area, it will have a lesser transmission of pressure, and if it is a less compliant alveoli, this will more transmission. So this results in better oxygenation of this alveoli compared to this which already does not, and this results in a better VQ mismatch. Also, it is important because the pressure transmission on the other side, if you look at, if there is any kind of an airway resistance, whether it is part of a secretions or whether part of a meconium aspiration syndrome, if it cannot go further, there is a lot of dampening here, but at the same time behind this, there's a lot of pressure generation which may go to the compliant alveoli, and hence it is important to take care of the airway resistance when you're giving a high frequency ventilation. So question people would often ask is, why should we even use a high frequency ventilation? Now, high frequency ventilation, people would use it for two reasons. One, if there is a difficult to oxygenate baby, so you have done a ventilation with a conventional ventilation and you start, and you just cannot get hang of the oxygenation. You want to try a different modality, and there, in that case, it's called a rescue ventilation. The major interest in high frequency in the recent year has been to reduce the ventilator-induced lung injury, where because as I said already, there is a higher pressure and a lower oscillations, and animal studies have shown that low tidal volume and a higher peak is something which prevents injury to the lung. So many people have started using high frequency ventilation as a primary modality in homogeneous lung disease, I will just talk about. So if we use it for high frequency ventilation, we first want to understand, is high frequency ventilation actually lung protective? Now, theoretically, yes, for two reasons. One, the lung volume at all times, especially if you're taking care of the critical opening pressure, is in the zone which is so-called the safe zone, avoiding the atelectator trauma. And at the same time, because the tidal volume is low and less than the anatomical dead space, so it avoids the upper part of the curve, which will lead to volume trauma. So theoretically, yes, if properly used, high frequency ventilation has a chance to be lung protective. And when, as I said, this the same diagram, if you see, compared to the conventional ventilation, as I said in the mechanism slide, there is a dampening. The blue lines that you see of a high frequency ventilation, by the time it reaches the alveoli, there is a significant dampening of the airways. Whereas the pressure in the conventional ventilation, suppose this was somewhere around 20 or 22, remains the same in the larger airways, remains the same in the alveoli. And if this is a non-compliant lung, for example, an HMT, you want to increase the pressure to achieve a higher MAP. The MAP in the CMV and the HFV increase, both of them increase. But again, you should see HFO, although the magnitude is higher than the compliant part of the lung, the transmission of pressure still is within the range where it is not going to be like damaging to the lung. Whereas if you see, you increase the MAP and a PIP to 35, the same PIP gets transferred to the larger airways and gets transferred to the alveoli. So higher pressures, there your chances of having a ventilator-induced lung injury with a larger breaths and larger pressures, both because of the volume trauma and the barotrauma, is significantly higher in the conventional ventilation. So when we start the HFO, there are certain knobs. So unlike many other conventional modes which are there, and anytime you see a new ventilator, they will come up with 2 or 3 new modes which you will have to learn about, but mostly not use them because we'll stick mostly to assist control or to pressure support ventilation these days. But this is a simplest machine because it has either a valve or a knob to control the gas flow and to generate, which increases the MAP. It's in some ventilators like SLE or they have an obstruction to the flow which generates MAP, and then to drive the CO2. These are the parameters: the amplitude, the inspiratory ratio, and the frequency. And I'll come to each one of them. We have been conventionally told that in high frequency, oxygenation is different and carbon dioxide is different. So to manipulate oxygen apart from an FI2, you need to just manipulate the MAP. And to change the carbon dioxide, you just need to change the amplitude. To some extent, that is largely correct, but that's not the entire truth, because change in MAP can also change the amplitude and the carbon dioxide, a concept which we'll talk about when we talk about the high frequency ventilation. So oxidation, apart from the MAP, is the recruitment of lung. So using an increase in MAP, unless you have recruited the lung appropriately, is not going to give you the benefits which you're looking for when you're using a high frequency ventilation. And carbon dioxide, Amplitude, apart from amplitude, is the frequency, and this unfortunately has been neglected. When we learned high frequency as part of our medical school, everybody told us, I just fix up any frequency, that doesn't matter, it's about amplitude and map, because that was the simplistic understanding of high frequency at that point of time. But as you will see, the frequency, i.e. ratio, and disease process itself, like what kind of a disease you are managing, would also determine how much of the carbon dioxide. Sometimes you'll be surprised, pneumothorax, we say use lower map. Sometimes you may just need to use a higher map or lower map depending upon what is the disease process, and of course the volume guaranteed, as I said. So map, again, in this, when we'll talk about the map, there are certain things that you need to understand. We need to increase the map. It's not only about increasing map. Suppose you are here in the atelectic zone. Even if you reach here, you're not going to get the benefit of really increasing the map, because you're still in the zone where alveoli are derecruited, not going to be benefiting. So you need to somehow reach this safe window, which is the most compliant part of the lung, and where the risk of atelectasis is low and the risk of over trauma is also low. So then when you look at this safe window, there are two limbs to it. One is that which is on the inspiratory part of the limb, and one is on the expiratory part of the limb. So in high frequency ventilation, you want to be on the expiratory part of the limb. And the reason is simple, because if you see this, for you to be in the safe zone, if you have to be here, you will be a much lesser pressure than if you want to be on the inspiratory part of the limb. So the pressure requirement to be on the, so when you talk about open lung or you talk about high frequency, you want to be here, not here, although both are in the safe zone. I hope the pointer is working fine enough for you to understand. So when you set a map, you have generally we see high volume strategy or low volume strategy. In fact, most of the earlier trials which failed and did not show the promise as the high frequency was supposed to be, did not show the promise, largely because they used a low volume strategy. They started at the map 1 or 2 centimeters below the map on the conventional ventilation. Whereas the sensible approach would be to increase and start a map at 1 to 2 centimeters above the conventional ventilator. I think it's got reversed. The air leaks, PPH, and pulmonary hyperplasia because of the fragility and high risk of pneumothorax, and meconium aspiration, partly, at least in the initial phase. These are where probably a low volume strategy is something which is more relevant. Whereas, where you have a homogeneous lung disease like a RDS or a chemical or infective pneumonitis, in that condition, using a higher volume strategy is something which is going to benefit the child the better, rather than like using a lower lower volume strategy. So there are other parameters. Again, as I said, because there is one value on the machine where you either in a sensormedics you change the flow, or you in the SLE you just increase the map. There are other parameters that you need to understand when you're setting the map, and this is again many times does not get talked about. So there is an IE ratio. So when the inspiratory ratio goes low, inspiratory ratio is low, like 1:2 versus 1:1. The transmission of pressure is definitely lower in the in the 1:2 ratio and 1:1. So an I ratio would also determine how much the pressure which is being delivered to the child is being maintained. So when you're changing, for example, you are on a map of 12, so you are changing from a pressure of 1:1, then you want to make a 1:2 change for whatever reason, then you need to increase the map by 1 to 2, and this often gets missed, and the process there is a de-recruitment because you've changed the ratio because you want to get the carbon dioxide out, but in the process you've lost the MAP benefit because the transmission becomes lesser. So always when you're changing the IE ratio, it's a good idea to change it by 1 or 2 on the upper side. The transmission of pressure is also dependent on the ET tube. So it's important that whenever you're changing the ventilator, whenever you're changing or switching over to a ventilator which is high frequency, it's a good idea for you to use the largest size of the tube. So maybe it means that you need to re-intubate, but you take care of the secretion suction before that. But you would want to use the maximum for the maximum delivery of the pressure to the into the lower part of the lung. And different frequencies have different effects. Smaller the frequency, in one nutshell, if I had to say, you would probably say the better the transmission of the MAP. But if you're going slightly on the higher frequency, your drop in pressure is slightly higher. So you may just have to account for that factor when you're changing frequency in a fixed MAP. So here comes in the concept of lung strategy. Till this time, it is something which has been there in most of the presentations. So what we need to now talk about an open lung strategy. The open lung strategy, as it refers, refers to a dynamic process of opening the previously collapsed lung unit by increasing the transpulmonary pressure. So you increase the pressure to open up the lungs so as to get them into a more compliant part of the lung. So for that to understand, you have to understand two concepts. One is an opening and a closing pressure. So take a simple balloon. Once you blow the balloon, you need a large amount of pressure by your mouth to initiate that breath, to initiate that dilatation of the balloon. So once the balloon opens up, then it takes a lesser amount of pressure by your chest or your lung to keep that lung expanding further. So that pressure where you need to use that maximum pressure to open the lung suddenly is what is known as an opening pressure or critical opening pressure. And when you open the blow the balloon distends, and eventually reaches a capacity beyond which it cannot extend further. And when you release the pressure, that it releases, but after the pressure, if you let go of the pressure, suddenly at one pressure, it suddenly collapses. And that is what is known as the closing pressure. So it is something like this. You have a lung, similar thing happens in the lung. You have a critical opening pressure. So you have seen a pressure going from here right up to here, and the lung starts opening. And once the lung starts opening, recruiting, then it starts having, getting into a better oxygenation. And you keep increasing till a point the oxygenation improves. But after this, any further application of pressure actually does not change the volume and does not change the oxygenation. It's a wasteful part. So then you go back, you deflate, and start deflating where you come back again into the compliant part of the lung. And at this point, which is now called the critical closing pressure, suddenly the lung goes back into the de-recruitment. So as I said, your job or your intention is to be on the expiratory part of the limb and somewhere here, because if you see the critical is somewhere above the critical closing pressure because it's much lesser than the critical opening pressure. So you're going to have lesser MAP requirement to keep the lung open compared if you want to be on the inspiratory part of the limb. Another concept which is important is that we know when you give surfactant to a lung which already has an atelectasis, because once there is atelectasis, there is a leakage of the pulmonary fluid inside. There are injury, there are cytokines, there are enzymes, which even if you give surfactant, is either going to inactivate it or is going to cause damage to the endogenous surfactant which is being produced. So as a result, the surfactant which is being given would cause, like, it's going to a cycle where the surfactant dysfunction happens, and you do not get the desired result with the surfactant being given. Also, the opening the lung actually preserves and prevents the ventilator-induced lung injury, because if you look at a balloon which is partly open, or filled up with air, where there are two kinds of strains which happen in the lung. One is the dynamic strain, where the lung opens and closes, opens and closes. And the green one is the static strain, which is because of a single, dilatation which is there. So, which is permanently there. And larger the strain which is dynamic, like this, then you're larger the chances of a ventilator-induced injury. So you want to reach the same oscillation with the help of a larger static strain and lesser dynamic strain. So these are two lungs. If you look at, they have the same strain. These are adult lungs, pig lungs. So obviously that's not something which we can extrapolate only to the neonates. But this is for an example, just to show that the tidal volume here is large, the dynamic strain is huge, and there is zero PEEP, which is 0% static strain. And look at the lung, which is completely mottled and injured. On the other hand, if you look at a global strain, this is the same, but that is largely, the strain is largely because of the higher PEEP, and the tidal volume is low, so it gives almost 80% static strain. And look at the lung, which is completely healthy. So this is something that we need to be, understanding when we're looking at an open lung strategy. Now, how do we apply this open lung strategy into the clinical practice? So if you look at this, like, we have all heard about this intubation, surfactant rapid extubation, so-called the INSURE technique. And everybody is using these days because of the concerns about mechanical ventilation causing damage to the lung. But what I want you to understand, or to get your attention to, is a new concept called INREC-SURE. So in means like intubation, recruitment before giving surfactant, and then once you reach, you can gradually, rapidly extubate the same way you would go. And the recruitment, as I already said, is required because to preserve the surfactant, reduce the ventilator lung injury, and to get a rapid response. So how it is done is that you set, I'll show you on the graph also, but just for those who want to just read that, you set a pressure. So you start, get a baby, you start a pressure at say 8, 10, whatever you generally start based on the size of the baby, and then gradually increase the FI2, because most of the FI2 is generally somewhere between 80 to 100, because the reason you have shifted the child onto the high frequency is either you have failed conventional ventilation, or many times if you're starting with the primary mode of high frequency, so somewhere between 60 to 100 is the opening FI2. But you keep increasing without affecting, changing the FI2. You change the map, increase the map by every 2 centimeter water every 2 to 3 minutes. We tend to do it every 2 centimeters. So if it was on 10, we do it 12, then 14, and keep increasing, because, as I said, the inflation on the inspiratory part of the limb is a little difficult, but you need to give adequate time for the child to get adjusted to the new map. Some people feel 3 minutes may be a little too less, and they use a slightly higher time, but then it's an individual variation. But you reduce the FI2, once you've done, there will be a time where your FI2 starts the requirement going down, because once the lung is opened because of this recruitment, the lung has opened, all the alveoli are functioning and being part of the VQ mismatch. In that scenario, their FI2 requirement goes down. So keep decreasing the FiO2 requirement till you will see that the child has, the opening pressure is, so you get smaller than 0.5 when you think your able is not able to find out with any increase in the map. So you started at 10, you reach 12, 14, and you see the FiO2 requirement going down. You increase to 16, your FiO2 requirement went further. You increase to 18, but you see no further change. You think that now you have found out there was like around 14, there was an open pre-surfactant opening pressure, which you can do, but definitely going to 18 would not benefit because you're now on the upper part of the curve. So then you do is like you go the reverse way. Come on to, because your idea is to be on the expiratory part of the limb, so you decrease the map. Here, instead of 2, we do it by 1, but again, there is no definite guidelines how to do it. So we do it every 2 to 3 minutes, decrease it by 1, till SpO2 falls. Because it falls because you have gone beyond the closing pressure, and then there is atelectasis, and the atelectasis, once sets in, the FiO2 requirement goes up and the child starts desaturating. So this will tell you that the pre-surfactant closing pressure. So you decrease from 18, 16, 14, 12, and after 12 you further decrease, it dropped. So this will help you determine the pre-surfactant closing pressure. So your idea now is to somewhere go back to the same route of expansion like 12, 14, 15, 16, go back and be about 12. Okay, because the closing pressure is 12, you need to be on 13 or 14. At that point in time, you have recruited lung enough, you are in the expiratory part, you give the surfactant, and after you give in the surfactant, your compliance starts changing. After 5 or 10 minutes, what you start doing is to reduce the map further, because you know, okay, this is now when you are say at 13 and you give a surfactant, compliance has changed, you further decrease, and once surfactant of course has produced a reflux, but a certain amount of pressure is still required. Say for example, at 8 or 9, your lung starts collapsing again, you start desaturating again, then you know you have found the post-surfactant closing pressure. So that means suppose at 9 you started collapsing, you want to be at 10 or 11 after giving surfactant. So you found, you go back, open up the lung again, and then, once you open the lung again, you come back to the post-surfactant optimal continuous, distending pressure. So on the graph, it will look like something. So this is a graph which is pre-surfactant. So you say, and these are all hypothetical numbers. I've put it for explanation purposes. So you started here at say 10 map, you increase to 11, you reach 12. And at this time, once you reach 12, 13, the oxygenation starts improving because now you have recruited part of the lung. You're further recruiting, and at 14, you have like significantly recruited. And after that, you may have some benefit, but largely there will be no further increase because most of the lung units have recruited. So from 14, for example, you go to 16 or 18, you will hardly find any further decrease in FiO2. So then you come back, and so you see, you reach here, and here at some critical point, that is the critical closing pressure. Suddenly, when you go down further, you will get a drop in because now you are in the, your lung is starting to de-recruit again. So say, for example, at 9, you found that after 9, you would probably, this child would have had a atelectasis. You go back, you go through the same route again and expand the lung, go back, and now you stay here. You stay here because 9 pressure, the lung collapsed, but you want to be at 10 or 11. And that is about the closing critical pressure of a pre-surfactant lung. After you've given a surfactant, the compliance changes. So once the compliance changes, okay, this is like, so your compliance, so you are here, because you're in the expiratory part, you see your compliance is low, you further decrease it, further decrease, and then here in the post-surfactant lung also, it will decrease, so that okay, this is all hypothetically, but for example, that 7, you found that the pressure decreased. You go up, expand the lung again, find out the opening pressure, and then again go down this limb. So you found that 7 was the criteria. So you'll stay at 8 or 9, and that is how within a span of few minutes or less than half an hour, you would have substantially reduced the pressure requirement, and at the same time, reduce the, open up the lung. So I'll just give you an example, which the baby which was there at our unit 1 week back, and this is a baby who was 500 grams at birth and had to be intubated right at the birth. It was difficult to ventilate this lung, and we had to put him on, transport him on 100% oxygen. But then we started ventilating and giving him, PEEP, and I'm just showing few pictures for the sake of this thing. So we increased the map, gradually started at 10, increased, and what you see is the frequency set at 15. And I'll come, because 500 grams babies are very small. So we map 15. At 15 we found, like after 14 we found, within there was an increase in saturation, and the Fi2 decreased from almost 90% to 28%. So what we did further was next, kept decreasing again and again, keeping the Fi2 same. We decreased the pressure, and suddenly the Fi2 started going down. So we found out that the critical closing pressure of this lung was 12. So we went through this procedure again, went and gave surfactant when the map mean was around 13 or 13 or 14. I don't exactly remember, around that. So then, we went through this, and the closing pressure, you could see in the next half an hour, we could reach and ventilate the lung on 20 to 24% Fi2 and a map of only 9, with maintaining the saturation. So this is how you would want to use a high frequency for most of the homogeneous diseases, as you could say. So this is about oxygenation. The second part is about managing the CO2 removal. As we said, this is about an amplitude and oscillatory volume that we need to be talking about. And oscillatory volume is something which we see on the baseline map, the oscillations which go up and down. So whenever the oscillations increase, you see the area under the curve increases. So there is a larger volume displacement, and as a result, there is a higher the amplitude, higher the volume. But as I said, most people would tell you whether the map and the oscillations are independent. That's not true. When you do an open lung strategy, you see as you improve the lung, as the lung compliance also increases, the CO2 also starts going up. The tidal volume starts going up. So you may see a CO2 drop precipitously here because so it's not that the tidal volume is independent of the map as conventionally told. How to set the amplitude? So you just look at, there is no guide, but you would probably see, we'll come to the DCO2, how it's measured, but you would also have to look at the, wiggling oscillation and decide whether this is so in the edemated chest, it may be difficult to see. So you look at a second intercostal space, but always see it from the side, not from the front, because you will have a parallax error and you may over or underestimate if you're looking from above rather than from the side. And as I said, consider the disease characteristics, because as I said, if you look at this lung, for example, as the compliance improved, the oscillations increase with the same kind of phase. So you don't assume that the same delta P will cause the same CO2 retention as the disease progresses or improves or worsens. Now, frequency is something that you need to understand. Unlike the conventional ventilation here, with the high frequency ventilation, as the frequency decreases, the volume which is covered, largely because as the frequency increases, the inspiratory time increases, the volume increases. So you will have, with a lower frequency, your CO2 removal is higher compared to a higher frequency, as you see. So the tidal volume is higher at a lower frequency than at a higher frequency. And this is completely reverse of what happens in the traditional conventional ventilation. On the other hand, if you look at like alveolar ventilation and among the two parameters, whether frequency or the oscillations, because the alveolar ventilation in high frequency ventilation is square of the tidal volume, so major change in oscillation is much more going to cause a change in CO2 compared to the frequency. So that is why conventionally we taught that tidal volume is the the oscillatory volume is the one that you should attempt to attempt to change frequently. Now, I ratio is something which often gets neglected, and either most people would not know about it, or they would just like, because sensor medics, people would say set at 1:2, and that's for all times you need to go. The previous versions of SLEs were giving you 1:1 by default, and the dragger also wants you to do 1:1, but you need to understand like why is the 1:2 available and 1:1. So when you look at the high, say for example, the 1:2, say 10 frequency, the tidal volume at, the inspiratory time is 50 milliseconds with a 1:1 ratio. But at the same frequency, same tidal volume, the inspiratory time decreases if we decrease from 1 to 2. So once the inspiratory time decreases, the tidal volume also, marginally decrease. The effect, fortunately, is less at a higher frequency, but when we talk of very small frequencies like 5, 6, 7, which you use sometimes for airway resistive diseases, the change in frequency can make a huge change in the tidal volume. So this is something which one needs to, consider, and especially you see there is a concept called corner frequency. I'll just explain to you, but in HMD where the compliance is low, the resistance is low, when you use a higher frequency up to 8, it is fine. After that, because the time constant is so low, so most of the lung is already filled because the time constant is only 15 milliseconds. In 45 milliseconds, most of the lung is already filled up. After that, even if you decrease the frequency further, it is not going to make any difference. So with the HMD lung, you want to be on the higher side of the frequency, not the lower side, because it doesn't benefit. And so with CLD, for example, because it takes a longer time because of a lower compliance but higher resistance, it takes a longer time for the 3-time constant to fill. So a lower frequency may be a better benefit in such scenario compared to the higher frequencies. Now, you need to understand a concept of a resonant frequency. I'll just go through that because so resonant frequency is so resonant frequency is like, those who have actually gone under a swing. So when the swing goes from one side to other side, so the child applies very little pressure at the right moment for it to go further and further. So it is, the initial part is like difficult, but once you go into a momentum, you need to apply frequency. So your frequency of this lung matches with the frequency of the child. So that it tends to cause further distribution, distribution of power. So I'll just show you one example. So you see, so if you see this man, so he starts blowing his sounds like with his voice sound resonance matches with the glass frequency, and because once the match happens, the glass breaks just because of the voice. So that is why you want to get a frequency where the transmission of the pressure is maximum. So if your lung is out of proportion to the frequency of the deliver you set on the ventilator, then you're going to have a mismatch distribution. So what we understand from the HMD lung, they tend to have a high, resonant frequency in this range, but a corner frequency, after which further the dissipation of pressure has no value, is higher in HMD and in the normal lung to some extent. In high resistance cases like meconium aspiration, chronic lung disease, there the corner frequency is set very low. So again, where there is high resistance, meconium aspiration, CLD, you want to use a lower frequency compared to a higher frequency because you want that much benefit to incur to the child with the same map being delivered. This is a rough guide, but again, as I said, preterm RDS, you see that 500 gram babies, we have set a frequency of around 15, and that is what we need to do here. And as you see, meconium aspiration, cystic PI, the more the obstructive component, more the resistive component you want to get on the lower part of the frequency curve. So in rescue mode, when do you consider giving high frequency? So there are no guidelines, but the whole idea is where you feel uncomfortable about the high pressure. So some people would feel uncomfortable at a map of 22, some people, peak inspiratory pressure of 22, some people with 24. For us, like, we are a little bit more aggressive, and like anytime it starts going more than 20, then probably we'll be more than happy to switch over to high frequency early rather than late. Especially if it is a homogeneous disease where we think we need to also do an open lung strategy. So when we start high frequency, we should, as I said, tube change is something which I showed you why it's important. We don't give muscle relaxant routinely, but sedation may be something which will depend upon the baby, and it helps reduce the fighting. Suctioning, because airway, if there is a lot of water or secretion inside, that's cause a problem in terms of delivery of the pressure. And because the map would increase, there is likelihood of hypertension. So it is important to actually look at correcting the hypertension and giving a fluid bolus if required, and then starting the pressure. So in a rescue mode, we look at the underlying disease, and we have to have a clear plan for ventilation. But we start at P1 to 2 levels higher, as I said, at MAP, which is either same or +1 if you're using a IE ratio of 1:1, or 2 to 3 centimeters higher if you're using a ratio of 1:2 than the MAP on the conventional ventilation. The oscillatory, the amplitude we set generally at 1.5 times the delta P of the conventional ventilation, or some people would only look at a wiggle and then give it, and then corroborate it with the DCA2 level and the ABG level. CMV breaths are available in some of the ventilators. This is only animal data, so there is no evidence that this is a benefit. So we don't use it. We don't recommend using CMV breaths on top of the high frequencies in the Cpap mode. Now this brings us to an important concept about volume guarantee. Now, as I said, like there is a chance there's a high frequency with the square of the tidal volume, there is a higher amount of CO2 which gets washed out. And most of the data which came from early trials on high frequency showed that there was an increased risk of IVH, largely because there was a change in the CO2 either too high or too low because of the rapid changes in the CO2. And because the CO2 changed, the intracellular blood flow changed and resulted in a higher amount of change. So which you see, I showed you the same diagram. So once, especially when you're using a high open lung strategy, your tidal volume increases because now you're on the compliant part of the lung, and correspondingly, because you are here, your tidal volume is increased, your CO2 has gone dramatically low. So here, if you had some mechanism to control that oscillation and not to go like this, it would have stayed like this, then the CO2 would have been more in the normal or near normal range. So this is a volume guarantee, which is there in now Fabian 6000 and some of the other VN 500. So where you set a tidal volume, the same as in pressure control mode, set an amplitude limit, and then use, it doesn't do breath to breath changes, but it changes over next 2 to 3 seconds. So you set a tidal volume, and the amplitude limits you set So it can go in between there. So it does not allow too much of a change in tidal volume and too much of a change in correspondingly the CO2 levels. So hence, hopefully, although we do not have a large amount of data on this on the clinical outcomes, but if you look at the crossover trial where people had used, where they said when you use a high frequency and a volume guarantee, the chances that the child would stay within the normal normal tidal volume range is 80% compared to what you set at in the high frequency without the volume guarantee. In Indian scenario, it is more relevant also because most of the units do not have a transcutaneous monitors for CO2 estimation, and also because the smaller babies have a fragile skin. So if you use the transcutaneous also, it tends to come off. And using frequent ABGs also would result in too much of blood loss. So this strategy, although again, as I said, clinically not proven, but maybe something which is worth. What is the amount of tidal volume? Maybe somewhere between 1.5 to 2, but you will still have to corroborate it with the ABG and the DCO2, which I'm going to come. So it's not only about going into the war, but you should also know, like Abhimanyu, how to come out of it. So weaning is something which we attempt oxygen because of the oxygen-free radical. After that barotrauma, we need to keep the MAP, and MAP we reduce. After that, frequency, some people keep it same, or some people would theoretically say because the lung has improved, your time constant is, so you may just want to decrease the frequency rather than change the frequency. It's not necessary to shift over to CMV. You can, once you reached a MAP of around 8 to 9, depending upon the size of the baby, you could possibly, and FI2 between 25 to 30, you could possibly go on to a non-invasive mode of ventilation without switching over to CMV. But those who are trained and conventionally used to changing from high frequency to CMV possibly could do that. Monitoring requires an X-ray. Initially you require it 12 to 24 hours, but ABG you would require frequently, especially if you're not using a high volume guarantee mode and you're not using a transcutaneous. But you have to corroborate it with the DCO2, and I'll just come in a minute. You have to monitor blood pressure and urine output very vigorously because hypertension is a significant event, especially when the lung improves. Now, DCO2 as a modality in the last few slides it's not a measure of CO2. It's a mathematical model which predicts CO2, but it's not the actual CO2. So it's basically square of the tidal volume into the frequency. So for example, if you have a tidal volume of 10 and 10 is 100, frequency of 10, so DCO2 will be somewhere close to 1000. Now, when you do, so hypothetically, I'm just saying it's 1000, and you find out that the CO2, the corresponding CO2 in the blood gas is 40. For a DCO2 of 1000, the CO2 is 40. So now, as the lung improves or worsens, if the DCO2 decreases, for example, the decrease means that either the tidal volume has decreased significantly, and in that case, the alveolar hypoventilation is happening, so your PCO2 is likely to increase. If the PCO2 increases, but the magnitude of change is not a linear correlation with the CO2 change. You cannot say it decreased from 1000 to 900, so you will expect the CO2 to drop from 40 to 60. So there is some change which you need to corroborate again with the next ABG or a transcutaneous. The whole idea of DCO2 is to maintain it at a stable level, and that helps in avoiding frequent, and these are the rough DCO2 levels where you would probably see for different ages of the baby. So important as far as when not to consider high frequencies, when there is a pre-existing hypertension, first you would like to correct hypertension, otherwise your blood flow is going to decrease and you're going to cause VQ mismatch. If it is black lung PPHN and you're trying an open lung strategy, you're going to increase the MAP, decrease the perfusion to the lung, and cause further VQ mismatch. If there is severe obstructive airway disease, in that scenario, maybe it may be counterproductive, although, sometimes you have to use it to get the, carbon dioxide out. And severe inhomogeneous disease like MAS, it may work or may not work depending upon what so you still have to try. Like when it comes to MAS, you need to understand it's not all and none phenomena. So MAS, for example, initially when there is a valve mechanism, there is air trapping with significant CO2 trapping, lower frequency and lower IE ratio to get the oxygen, carbon dioxide out is the strategy that you would want to use it. On the other hand, once the chemical pneumonitis sets in, the patchy atelectasis sets in, then you want to use in the same patient a higher frequency with the lung recruitment based on the chest X-ray as discussed in the open lung strategy. In air leaks, we thought initially that this is a better strategy. Unfortunately, the data suggests that probably the incidence of air leaks is slightly higher because of higher incidence of PIE in high frequency. But when you use it for pneumothorax, for example, you use a low tidal volume ventilation, higher frequency, so that the lesser MAP gets transferred and a lower, and no superimposed conventional breath. For a significant PI, you use a lower frequency and a shorter, IE ratio to may enhance the resolution of the disease. And lung volume recruitment is best avoided. But at the same time, you have to maintain some MAP to keep the airway open. Otherwise, if the airway collapses, there is the airway collapses, especially the proximal airway. There is a trapping of air beyond that, and this will lead to more air damage than helping the child. Jet ventilation does help better, but we do not have an experience, and largely because they use a very high IE ratio of 1:4, 1:8, and the expiration is largely passive in jet ventilation compared to the oscillator. In PPHN, again, as I said, if it is secondary to a lung disease, you use the open lung strategy. And if it is a black lung PPHN, idiopathic PPHN, you probably use a lower lung strategy along with an inhaled nitric oxide. So when you use high frequency, there are a couple of factors that you need to consider. The breathing circuits cannot be compliant. Otherwise, most of the pressure would be lost in the circuit itself. Use a smaller circuit and use a humidifier chamber which is maximally filled with water. So don't, if you have two values, minimum and maximum, keep it towards the maximum most of the time so that loss of volume does not happen in the chamber. And when you're using the shortest tubing, because many times beyond that limb, where the temperature probe is attached, there is always a limb which goes into the incubator. So you can either get rid of that and use the shortest possible length to get the delivery of pressures inside the lung. Use heated circuits and avoid use of water traps because they will also lead to volume loss, and avoid condensation in the breathing circuit because that will increase the resistance to the airflow, which will further reduce the pressure delivery to the baby. So there is irritation which is expected when you're using and may need sedation. Secretions is significantly high, so use a closed section. And this is one other thing that you need to remember. When you are using a high frequency, if you disconnect the ventilator, you suddenly all that lung you opened is going to fall back. And you would again, if you have by any chance done it, you want to go back and increase the MAP again to a level where it is going to open the lung again. It's better to use a closed suctioning without the need to disconnect from the ventilator the suctioning. If it is too dry secretions, necrotizing tracheobronchitis, hypertension, and intraventricular hemorrhage, which I just and the last slide which I showed you, the evidence, unfortunately, for high frequency versus CMV, there have been 16 studies, and most of the time they have not shown any benefit, only a very marginal benefit in reduce the BPD. And so that is why most people still are not using elective ventilation as a part of their strategy. But again, as I said, open lung strategy with a volume guarantee, that a lot of data is not available. And unfortunately, most of these comparisons have been done when people did not use volume guarantee, which is supposed to be lung protective in the CMV. So we'll have to look for a long-term data on the newer modalities to find out which is a better modality in the long run. But at least the 2-year follow-up shows no difference in neurodevelopment outcome, maybe marginally better in the high frequency. And a subgroup of the trial in Britain showed that 11 to 14 years follow-up, there was a better lung function in the high frequency. Among the preterm and the term infants, the rescue modality, there is no benefit of one over the other. But since you have failed one, you would probably use the other modality, the high frequency. The benefit partially could not be because there were largely very early trials when there were no antenatal steroids, and they were in the pre-surfactant era. To summarize, so we need to look at know the machine first, know the baby, the size of the baby matters, the disease matters, and the pathophysiology matters. It's just not, stitching the lung because you failed on conventional ventilation. Always remember that you need to recruit the inhomogeneous, de-recruited lung to get the benefit out of MAP. Otherwise, you will say that high frequency does not work. It has failed. And frequency is important, is not as unimportant as most of the lectures would tell you. That if you set the frequency right, you'll probably incur much more benefit than just ignoring this as one unnecessary knob on the ventilator. Thank you. And I think it's a little long, but I think high frequency is such a big topic that you still have much to cover. But I think we'll take some questions. If Dryas, are you there?
Yeah. Yes, doctor. Thank you so much. I think very nice, informative presentation. So we have a lot of questions, but I think we'll try and address the most important ones. So the first question is that, is HFO effective in patients above 20 kgs?
See, honestly, HFO is effective in all babies, even older people use, adult intensivists use HFO in their unit. And but I do not have any experience because I have been only trained as a neonatal physician, so I've never used HFO in pediatric patient or an adult patient. So I may not be with the right person, but yes, in the neonatal population, it does work. And as I showed you, like the example, a live example of the baby, if used properly, then you will get the maximum benefit out of the benefit of the HFO.
Right. Thank you. So the next question is that, can doctors wean the baby from HFO to Cpap directly? Is it safe?
So in the slide I showed on the weaning, as I said, we tend to do like, at least I'm comfortable doing a direct extubation, and there is no data which suggests that you should necessarily go from high frequency to Cpap to CMV before extubating. So you could directly extubate if you're comfortable, but if you are not comfortable, you could probably go for a day or two, for a few hours on CMV and then get back. But a MAP of 8 or 9, you're quite good enough to get off the Cpap directly, off to Cpap directly from HFO.
Okay. So there's another question following that. Is HFO effective in anemic babies, and does NO help in improving the saturation?
I think when you look at anemic babies, the pathophysiology is different. I do not know why you're ventilating an anemic baby in the first place, but I'm sure there must be a coexisting lung disease along with that. But when you have a severely anemic baby, you're trying to give oxygen, but you need something in the blood to carry that oxygen to the tissue. So you would obviously want to optimize hemoglobin to a level of around 12 to 14, 10 to 14, or maybe around 12 to get the maximum benefit of high frequency. If you're ventilating, for example, a HMV with a hemoglobin of 5, then obviously you're not going to get any benefit. And nitric oxide is only to help a PPHN. And PPHN, if it is secondary to a lung disease, would HFO really help? Otherwise, HFO is not a treatment for PPHN. PPHN, if HFO is the treatment for PPHN secondary to a lung disease, like, for example, chemical pneumonitis because of meconium aspiration, and there is a secondary surfactant deficiency. You want to open the lung because of HFO, and you give nitric oxide along with it.
Okay, thank you. So there is a question which says that what is the importance of psi breath, SIGH, psi breath in HFO, and how does it help?
So as I said, the CMV breaths or the psi breaths are something which will keep the lung expanded for some time, and then you get back to the normal wiggling. So this is based on an animal data that you expand the lung for some time, it keeps, so the whatever is de-recruited, you expand the lung. But this is not, there is no clinical evidence to do what the ventilator guys ask us to do. So evidence-wise, it does not make sense to do that kind of a strategy. How harmful or good it is, we do not have a data. So we stay away from doing a psi breath or a CMV breath on top of the conventional CMV.
Okay, so there's another question which says, is HFOV results, does HFOV result in more chances of IVH in preterm neonates?
So the whole discussion we had initially, when we look at all that initial trials, like a Hfp trial, like the initial one by Martin Kessler and other people, they used either a low volume strategy or they used inappropriate frequency, and their oscillations were so rampant. And since they were not using volume guarantee, there is a definite increase in the incidence of IVH if you look at the older trials. But when you use it correctly, if you open the lung properly and you use a volume guarantee along with it, you will probably see the oscillations in volume are not too much. The perturbations in CO2 is not too much. And possibly the current data, if you look at the neo trials, do not suggest that IVH is such a big problem if you're using a right map strategy and using a volume guarantee.
So there's an interesting question which says that HFOV versus or between HFOV and HFOV with volume control, what is the difference and how to do the setting and what's the difference in the setting?
So it's like as I showed in the slide, high frequency, the oscillations would be unregulated. So when you do a conventional ventilation, so you do a pressure support with volume guarantee, if you know about. So there you set a tidal volume that I want to give 5 ml volume. So to achieve that 5 ml, you can set a limit of pressure about say 20, but to deliver, if the lung is good, you need to go only to the pressure delivered by the ventilator need to be only 12 to deliver that 5. Now, if the lung worsens, for example, to get the same tidal volume, because your volume guaranteed 5 ml, the pressure would go up to 14 or 15. If the lung improves, the pressure needed to be delivered by the ventilator is on the lesser side, maybe 7 or 8. The same when it applies to high frequency. High frequency, the tidal volume is determined by the oscillatory volume. So you say, I want a tidal volume of 1.6, and somebody asked the question, should we set 4 to 6 ml or 1.5 to 2? So it is somewhere between 1.5 to 2. The larger baby, you might want to use a slightly larger volume because there is a larger anatomy. A smaller baby, you may want to use a slightly larger volume because of a higher tidal anatomical dead space. But 1.5 to 2, suppose you set at 2. So to achieve that 2 ml, your delta P may be 10. Now the disease has improved, for example. So the compliance is improved. So you would, for maintaining the same 2, the delta P automatically with the machine would go down to 8. You don't have to do anything, but it automatically corrects. If you are not corrected for it, if there was no volume guaranteed available, so it will, despite the compliance, the baby's oscillation would have increased, the CO2 would have dropped, and the higher the chances of PVL and IVH as we just discussed.
Okay, thank you, sir. So there are a few questions I think which are grouped, and a few, doctors want to kind of to help and repeat and understand the map and frequency relation, and then there's a related questions to that. So if you could repeat the map and frequency relation.
Okay, let me like so.
Yeah, we are seeing the PPT.
Yeah, it is like something stuck. Okay. Just give me a minute.
Yeah, no problem. No problem.
Yeah.
No problem.
So the map is like, it's the map remains same, but the transmission of pressure, as I said, like, how much the pressure goes down if you give the higher frequency, the transmission, the amount of pressure to the lowest part of the lung at the higher frequency is much lesser compared to at the lower at a lower frequency. So with the same map, the transmission of pressure is lesser with the higher frequency and more with the lower frequency. And that is what you need to see. So that is why with an HMD in a lung, which is more or less non-compliant, you use a higher frequency. But as you decrease the map, you go, as the lung improves, you go towards the higher lower frequency then thereafter.
Okay, sir. So I think there was a following question, which I think some people wanted a clarification. So they are asking that, is it low and high volume or low and high map strategy?
Map strategy, sorry, so.
Okay.
Yeah, sorry.
Okay, fine. So there is one more question, which is, please comment on the plateau pressure.
Which is the question?
Please comment on the plateau, PLATEO, plateau pressure.
So, in the plateau pressure is I mean, as far as I understand, there is no plateau pressure in the MAP high frequency ventilation, because there is like always a continuous descending pressure. So, plateau pressure is somewhere in the continuous, or the continuous mandatory ventilation or the conventional ventilation, where you just rise and then you maintain that plateau for some time and then drop it. Whereas in the MAP, there is always a continuous descending pressure. On top of it, there are oscillations, and that is like, so there is no, I mean, and anyway, it's not clinically relevant to discuss them.
Okay, fine. So there's a question which says that, what is the max PEEP we can use to open the alveoli?
So PEEP is like, as I said, there is no max. So each child is different. So I showed you that child where it opened at 15. So when we say PEEP, we're talking of MAP in the high frequency. When we talk of PEEP in conventional ventilation, we're talking about the peak expiratory pressure. So you can use the open lung strategy in conventional ventilation also, for example. But if you keep the MAP on the higher side, to open. So you have to find the critical opening pressure for that particular lung, rather than just saying, okay, what map would work. There's not one single number which would work, but it'll work on a different kind of diseases, different kind of patients, a different value.
Sure. So there's a question which says that, how would you compare Cpap versus HFNC, or for managing the RD/RDS? If you want, I'll repeat. How would you compare Cpap versus HFNC for managing RD/RDS?
Okay, so this question, like, Cpap versus high flow nasal cannula. I think this is not part of the seminar because it's not a high frequency question, but still I'd like to answer. The Cpap is something, there are enough evidence now which suggests that for a primary mode of ventilation, where you want to treat HMD in the beginning, Cpap is better than high frequency, high flow nasal cannula. But when you come to extubation, both may work. You could use either, but for primary mode, use Cpap especially in the very small babies, because the chances of failure of Cpap are much higher if you use non-invasive is higher if you use a high flow nasal cannula compared to Cpap.
Okay. So there's an interesting question. It says that when do we use Hfp plus CMV, and how is it advantageous?
Sorry, come again, question there.
When do we use Hfv plus CMV, and how is it advantageous?
As I said, like, there is only an animal data. I would not recommend people using HFO with CMV because there is no definite clinical proven advantage of using CMV on top of. But sometimes some people use to recruit in between the lungs. But I would suggest go for an open lung strategy rather than using CMV in between and then de-recruit the lung again.
Okay, fine. So there's a compliment from Dr. Nilesh, who said excellent talk, and he's asking a question which is that any special scenarios in neonatal ventilation where you will change the I/E ratio on HFOV to 1:1 instead of 1:2?
So, like wherever, as I said, Nilesh, thank you for the question. If you have 1:1 ratio, your inspiratory time is higher. You are going to have a higher, map being delivered to the. So whenever your oxygenation is a problem, you want to go up on the I ratio. And when you use I 1:2, for example, you would want to use where you think there is a gas trapping or the lung has improved now when you are in the improving phase, or you think that there is an air trapping happening because of, say, PIE, you would want to use like a 1:2 ratio. But some people are more comfortable using. So Drager, for example, says you use 1:1. Earlier ASLEs used to have 1:1. The Sensor Medics, on the other hand, says 1:2. So these are just semantics. So I would probably not you go for the manufacturer, but 1:2 is definitely required when you have a gas trapping, going, and when your lung is difficult to oxygenate, 1:1 would be a better strategy.
Okay, thank you. So there's one question on what initial settings for hyaline membrane disease, for neonate. So there's no HYALINE. Yeah,
yes. So hyaline membrane disease is the RDS. There's no initial setting. As I said, I showed you that graph where you go one by one. So you go by start at maybe 10, then increase by 2 every time. See where the open lung strategy works for you, and then come back and do the whole process. You will probably have to go through the same exercise again I just showed for my baby in my talk. But there is no initial settings which are most appropriate. Most people conventionally start around 8 to 10. And as I said, or if they're changing from conventional ventilation, they're using 1 to 2 map higher than what the map was there on the conventional ventilator.
Okay, so there's a question on what are the indications of HFOV in PPHN and ARDS?
Sorry, come again?
Yeah, what are the indication of HFOV in PPHN and ARDS?
So, like, if your pulmonary, PPHN is secondary to a diseased lung, then you would use a high frequency ventilation. If you have a high frequency ventilation, PPHN, which is idiopathic, the benefit may not be huge, and you have to be careful because sometimes if you use in an idiopathic where you have completely normal lung, you use a very high pressure, your lung would distend further. It is over volume, and because of the over volume, your venous return is less. You will cause more VQ mismatch and probably going to cause more problem than actually helping the child. So you cannot say the diagnosis of PPHN warrants say HFO. It is what the PPHN is because of would warrant an HFO or not.
Here's an interesting question by Dr. Manish Mittal in Jaipur. It says that giving surfactant to a baby while on HFO means disconnecting from ventilator as side port ETT is not available. But doesn't it predispose to sudden de-recruitment of alveoli?
Very correct question, but as you said, we went up and we found out that particular baby's the opening pressure was 14 and the closing pressure was 12. So when we started, once you open, you would want to go back to 13. You give the lung and open the lung again. So the whole idea is there is no other way, as you rightly said, there is no side port ETT available nowadays. So you have to open, it will de-recruit, but the closing opening pressure, go back to there and then come back to just above the critical closing pressure.
Okay. So in case of HFO with VG, what is the range of TV? Is it 4 to 6 ml per kg
No,
or
4 to 6 is
1.5
for
to
conventional, 1.5 to 2 is like
okay.
on the volume guarantee.
Right. Yeah, I think that you've asked a minute.
The role of pulmonary graphics
in monitoring a patient on HFO.
There is no pulmonary graphics which like you can actually monitor except for monitoring the DCO2 and the tidal volume, which is depicted in most of the current HFOs. So you need to take a decision based on that.
Right. What is the starting and the max rate both in preterm and term?
So rate is like, as I said, it's the frequency in if you're talking about the frequency in preterm and term. In a preterm, you want to use a higher frequency, and in a term, you want to use a lower frequency. Preterm with for example, chronic lung disease, you want to use a lower frequency. In the preterm with the HMD, you want to use a higher frequency. So it depends upon the size, but mainly depends also upon the pathophysiology of the disease. So there is no maximum or minor. But beyond 15, for example, there is no benefit incurred. So that is what is known as a corner frequency. After that, there is no benefit acquired in reaching. And in case of term babies or preterm babies, minimum rate, if it is you go less than 6 hertz or 5 hertz, then there is no benefit. Like all the high frequency is called more than 2 hertz, 3 hertz, but less than 5, it doesn't really make a difference.
Okay. So the next question is, wiggling in HFO can lead to IVH in extreme preterms. So what is your thoughts on that?
So it's not wiggling. It's not the process of wiggling which actually shakes the baby and causes the IVH. It's the wiggling is a measure of oscillatory volume. So more the wiggling, more the oscillatory volume, and more the CO2 which is low. Lower the CO2 in the brain, more the chances of cerebral blood flow changes and IVH and PVL. So you need to allow wiggling only up to the umbilicus. That's the conventional teaching. But be sure that you either monitor it with the liver tidal volume or an ABG as soon as possible.
Okay. There's one question on, sir, how with lower frequency there will be increased CO2 washout?
Sorry?
Lower frequency, there will be increased CO2 washout. So
okay, maybe I need to go back to the same slide. You can see the slide,
yes,
slide.
Yes.
So
this slide is visible.
This slide, if this is the frequency, say this is like 6 hertz, hypothetically saying 8 hertz, and if you decrease it to 6, your inspiratory time is gone up, and the volume under the curve has increased. So and it's like, so that is why the more volume which goes out of the lung, or more CO2 gets evolved. So you will see, the larger slower the frequency, more the chances of CO2 coming out. And that is why how it is different from a conventional ventilation.
Fine. So there's a next question which says that if between HFOC or HFJV, which is better in newborns?
So there is some data to suggest that HFJV is marginally better because lesser incidence of air leaks and less trauma. But honestly, I do not have an experience of jet ventilation, and nobody in India has that machine. Jet ventilators are generally available in UK and US, but there are no jet ventilators which are available here.
Yeah. Doc, you can stop sharing the PPT because I think we're seeing a great thing.
Okay.
Yeah. Okay. Yeah. 9 last two questions. I think we're close to 9:30 also. Just two questions. So is there an arbitrary number to set frequency of 10 hertz for preterm and 15 hertz for term? And is it bigger the baby, more the frequencies to start with? And is MAP equal to convention FIO 2100 to start with and TV 1.5 to 2 ml kg? So somebody is asking if that's the right thing.
So TV 1.5 to 2 ml, that's correct. MAP equal to conventional. No, MAP should be slightly 1 or 2 higher than the conventional MAP, conventional ventilation MAP. FI2 100 to start with. Invariably, if you're using it as a rescue mode, you would have reached 100 FI2 before you start doing, but it's not necessary. You should want to go down on FI2 as soon as possible. Bigger baby, 10 hertz for preterm and 15 hertz for term. No, this is actually the other way around. Smaller the baby and higher the frequency. Homogeneous lung disease, low compliance disease, higher the frequency. If you have like a big, obstructive airway disease, like a CLD, lower the frequency.
Okay, and I think the last question for the day, I think it's also nearing 9:30. So how to not use water trap and also decrease condensation?
So there are two parts of this question. Like, generally, when we talk about this water trap, so you get heated air circuits these days. You get like either single heated, the inspiratory limb is heated completely, or there is like dual heating, which is like inspiratory and the expiratory valve, side both are kind of having the heating mechanism. So that way you can avoid a condensation. But the condensation generally can happen if the room temperature is like very low, and especially the major condensation happens with the incubator extensions of that pipe. So when you keep it incubator inside, as these tubings, they increase the compliance and the compressible volume. So if the incubator temperature is high and the extensions are needed, select the shortest extension with a stiff tubing and try to avoid using water trap.
Okay, I think there are lots of questions, but I'm sure we'll not be able to answer all of them. Most of them we've kind of asked, which are the important ones. So I think on the lines of this, Doctor, I'd like to thank you for a very informative and insightful presentation. I think there have been a lot of compliments from a lot of doctors across India who shared the same sentiments. And I think this presentation and webinar of yours has created a lot of captured all the intellectual property in one place actually, which can then be utilized and shared for the benefit of all. So thank you very much, and thank you for your time and patience and support. And so you could kind of end with a closing remark of yours. Thank you, sir.
So thank you. It's important that at the COVID time everybody stay safe, stay at home, and it's the best time to catch up on whatever we need to learn. It could be academic, non-academic, both. So I'm suggesting the academic should be only 50% of your learning, 50% should be other parts of it could be meditation, time management, and other things, because you would not care where all the people are a little concerned that at this time you have not much work to do, but take it as a blessing, and you have so much time to do other things which you normally would not get time. So as far as high frequencies ventilation, I'm open to any question or any discussion you want to have over the phone, because in the presentation it's not possible to cover all the things. So maybe operator can actually share my number to anyone who wants to connect with me beyond this webinar. Thank you so much, and good night.
Yeah, thank you, doctor, and good night. And thank you so much for all your support and yeah.
Right.